Hey, what's up, class? Today I wanted to give you a quick little lecture over shock. First off, I hope all of you are enjoying your spring break. Enjoy it while it lasts. When you get back to class, we'll jump right into it. So I know a lot of you had a hard time, even myself had a hard time with the pathophysiology lecture in class. Um, in order to be a good paramedic, I think the most important pathophysiology to understand is the pathophysiology of shock. So that's what this presentation is today. So we've got shock. This is the pathophysiology that you need to know. Just like always, a disclaimer for educational purposes only. It doesn't replace your formal education or your required readings, all of that stuff. This is just to help make you 1% better, okay? So during this presentation, we're going to define what shock is. We're going to talk about the physiology of it, how it works, what shock is. We're going to talk about compensatory mechanisms that the body has to deal with shock. We're going to talk about how we classify shock, how we figure it out, how we assess for it, how we manage it, and then just some other general complications and considerations. And then at the end, we got a few scenarios, so that'll be fun. We'll dive right into it. So, what is shock? So, shock is essentially inadequate tissue perfusion. Okay, so our bodies like to maintain a normal internal environment. We call that homeostasis, right? That's our body's kind of perfect normal. We like to stay in homeostasis in order to do all of our normal bodily functions in a normal way. So shock is a dysfunction of that homeostasis because of inadequate perfusion to our tissues. So there's a quote you'll see in a lot of books or videos. The quote is that shock is the rude unhinging of the machinery of life, and that's by Dr. Samuel Gross. Um, Indeed, shock is a major disruption of how our body normally operates. It disrupts homeostasis. Additionally, it is a shift from aerobic to anaerobic metabolism. So remember, our cells need oxygen and glucose to make energy. Um, in shock, because there's decreased perfusion, decreased provision of blood flow to our tissues, they don't have that oxygen and they're forced to use alternative forms of metabolism or anaerobic metabolism. Just like we talked about, aerobic metabolism uses oxygen and glucose, and as a byproduct, it also makes CO2 and water. Additionally, as that energy that we need, additionally it makes ATP, adenosine triphosphate, which is like the energy currency of our body. Now, when shock occurs, there's not adequate oxygen available. Our body switches, our cells switch to anaerobic metabolism. This is metabolism without oxygen. This is much less efficient. Aerobic metabolism with oxygen makes about 38 ATP, but anaerobic metabolism only makes around 2, so it is significantly less efficient. Also, anaerobic metabolism leads to the production of lactic acid. So lactic acid is a bad acid. It decreases our pH, and our cells also tend to die in a more acidic environment, so it just worsens the cell death. So not only are we having to switch to anaerobic metabolism, we're also making less energy, and we're also making more acid. So what's the heart doing in shock? So remember that the heart is a two-stage pump. There's a left side and a right side. The left ventricle is strong and powerful. It pumps blood to the entire body. The right ventricle is a little bit weaker. It's only got to pump blood to the lungs. Preload's an important term to be familiar with. That's the stretch of tissue as blood returns to the heart. Some literature will call preload the actual fluid that returns to the heart, but the important concept to understand with preload is the stretch of the tissue that you get when that blood returns. Now, Starling's law is also a good principle to know. Generally, Starling's law, it means the greater the stretch of a muscle, the greater that muscle can contract. So this is really important when it comes to the heart because the heart relies on stretch in order to contract harder, especially the stretch from preload. And then afterload is the pressure that that heart's got to contract against. So, for example, the left ventricle, when it pumps blood to the body, that afterload is the blood pressure within is all that resistance within our systemic blood system. Systole is the force within the arteries during contraction. and diastole is the force within the arteries during relaxation. You should all have heard of MAP before, or mean arterial pressure. This is the average pressure in our arteries. So an easy way to calculate this is you subtract your diastolic from your systolic. This gives you your pulse pressure. You take 1/3 of that pulse pressure and you add it to your diastolic. So if our blood pressure is 120/80, we subtract 80 from 120, our pulse pressure is 40. So that's the difference between the two. 1/3 of 40 is around 13. So we take that 13 and we add it to our diastolic, which is 80. So our MAP in a person with a blood pressure of 120/80 would be a MAP of 93. So that's how you would determine your MAP. So MAP provides us a little bit better depiction of how our perfusion's going all around. Okay. There's also shock index. So shock index is kind of a way to help you find if somebody's compensating or not. So shock index is your heart rate divided by your systolic blood pressure. Most literature suggests that greater than 0.9 is concerning. Essentially, what you need to know to be a good paramedic is that anytime your heart rate is greater than your systolic blood pressure, you should be concerned. That would automatically be a shock index of greater than 1. So anytime your heart rate is greater than your systolic blood pressure, that should perk you up and make you concerned that this is a more critical patient. Stroke volume is the amount of blood ejected from the heart during each contraction. Cardiac output is your heart rate times your stroke volume. So this is how much fluid your heart actually pumps in a minute, and it is measured in liters per minute. Some more good terms to understand. So you have systemic vascular resistance. A lot of times this is abbreviated as SVR. This is the afterload of that left ventricle, the force that the left ventricle has to pump against. There's pulmonary vascular resistance. A lot of times it's abbreviated as PVR. This is the afterload of the right ventricle. This is all the force that the right ventricle has to pump against. So things that increase pulmonary vascular resistance may be like lung disease. So like a patient with COPD, the right ventricle is going to have to work harder to pump blood to that because it's going to have elevated PVR, or elevated pulmonary vascular resistance, when somebody has lung disease. Your sequence of blood vessels. So we have arteries. We have our arteries. When they branch off into smaller vessels, they branch off into arterioles. These eventually ends at the capillaries. So the capillaries are where that gas exchange occurs. They may be a single cell thick gas exchange would occur, and then the deoxygenated blood would then flow into venules, and then those venules would join into larger veins. So blood vessel sequence, it goes arteries, arterioles, capillaries, venules, and veins. So smooth muscle controls the size of the blood vessel. Arteries typically have a majority of the smooth muscles. Veins are typically very low pressure system, whereas arteries are high pressure system. These smooth muscles within the walls of the blood vessels, they respond to sympathetic nervous system stimulation. This is your fight or flight. Additionally, you have alpha receptors that lead to vasoconstriction. So epinephrine, norepinephrine, these sympathomimetics or neurotransmitters or medications, they affect those alpha 1 receptors, and that causes the vasoconstriction of those smooth muscles within those blood vessels. So what is compensated shock? So remember, the body wants to stay in homeostasis and wants to maintain a normal internal environment, and it's got multiple ways that it can do this. So when the body is in a state of shock, but they're still able to maintain homeostasis, we call this compensated shock. So if there's some type of insult going on, some type of illness or injury that's putting them in shock, but their body's still able to compensate for it, keep their blood pressure up, keep their normal functioning, we consider this compensated shock. Most consider the transition to decompensated shock when hypotension occurs. Now, there are multiple ways that the body can compensate. So the sympathetic nervous system can help in compensation. In response to shock, the adrenal glands, they release epinephrine and norepinephrine. Just like we talked about, epi and norepi can lead to vasoconstriction. Also, epinephrine and norepinephrine, they can lead to inotropy. which is the force of contraction. So epi and norepi can lead to increased inotropy or increased force of contraction of the heart. They also increase chronotropy, which is the rate of cardiac contraction. So inotropy and chronotropy, these are considered beta 1 effects, okay? So the sympathetic nervous system ensures that the heart beats stronger and faster in a compensated shock state. Okay. Additionally, we have that alpha stimulation, the alpha receptors within those blood vessels. That leads to vasoconstriction. This helps increase blood pressure centrally. But unfortunately, it can kind of shut down and clamp down those capillaries. So we may get somebody with pale skin because they're shunting that blood to their core. Additionally, glycogenolysis is the breakdown of glycogen. This helps increase our blood glucose, gives your body a little bit more fuel to do what it needs to do. So patients in shock, you may actually have an elevated blood glucose as a shock response. Additionally, our respiratory rate increases and peristalsis, or essentially digestion or the movement of food through our digestive tract, slows down. This might be that can kind of explain why people may be nauseous um, or they may vomit, things like that. Aside from the sympathetic nervous system, we also have our parasympathetic nervous system. It doesn't really have a role in shock per se, but the functions of the parasympathetic nervous system is it decreases our heart rate, respiratory rate. It increases peristalsis, is kind of that rest and digest, so it increases those kind of relaxatory and digestive functions. Again, it's not really useful in shock. Um, when we're in shock, that decreased perfusion, it leads to the release of antidiuretic hormone. Antidiuretic hormone just keeps you from peeing, so it keeps you from losing all that extra fluid. Your body can use that extra fluid to try to help increase perfusion. The body reabsorbs sodium, and remember that water always follows sodium. Though this is a very slow process, and this is not likely going to help your patient in the acute shock setting. Once hypotension has occurred, the compensatory mechanisms have failed. And like we talked about, once that blood pressure starts to go, once they're hypotensive, they have transitioned into decompensated shock. Their body is no longer able to compensate. And then lastly, there's a term you may see, it's called irreversible shock. This is essentially the final progression of shock. This is when we can't fix it anymore. The body's not able to compensate, and we're not able to fix anything. And essentially, death is imminent. Okay. Um, Always treat your patients. Never assume like, oh, this is irreversible shock. We're just not going to do anything. That's not how it works. It's just a way to say conclusively, once all interventions are ineffective, the body would eventually be in a state of irreversible shock, and death would occur soon after. Now we're going to get into actually classifying shock. So, shock is essentially a problem with one of three components, either the heart, the blood, or the blood vessels. Okay, so we have hypovolemic shock. There are four main types of shock. Okay, so hypovolemic shock is the first one. This is really the easiest to understand. So, hypovolemic shock occurs when there's inadequate blood volume. So this can be from massive bleeding and trauma. You've bled out all your blood. Or it can be from something like severe vomiting and diarrhea. You're just a huge amount of fluid loss, and you don't have enough fluid in your body to perfuse and get blood and oxygen where it needs to go. The second type is distributive shock. So distributive shock, there are several subtypes that we'll get into, but the problem with distributive shock is there you have massive vasodilation. So all of your blood vessels have gotten too big in relation to the fluid within them. So your volume may not be any different, but because your containers are so big, the blood vessels are so big, you're not able to generate adequate blood pressure to get that blood and nutrients where it needs to go. So distributive shock is a problem with dilation. Cardiogenic shock is due to heart failure. The heart's not an effective pump anymore, so we can't pump strong enough to get that blood where it needs to go to perfuse. And lastly, obstructive shock. Obstructive shock is due to some external process that affects one of the three components. It may affect the heart, it may affect the blood vessels, but something has happened outside of the body. For example, attention to the thorax, pulmonary embolism, not necessarily outside the body, but it is a something has caused an obstructive process that affects either the heart, the blood, or the blood vessels. When you're assessing your patient, your signs of shock, they're going to be assessed by observing your major organs and your major body systems. So the brain, you may have altered mental status, not enough oxygen or glucose maybe getting to the brain. And the brain is very sensitive to hypoperfusion, very sensitive to hypotension. So you may get disorientation, anxiety, confusion. You may have tachycardia for the trying to compensate. Remember, those adrenals are releasing epinephrine, norepinephrine. You've got your beta 1 effects, your inotropy and your chronotropy, increasing your rate and your contractility. You may have hypotension. Additionally, you may have an elevated shock index. Remember, anytime that heart rate is greater than our systolic blood pressure, that should make us think shock. Okay, either compensated or decompensated. We may have tachypnea, increasing those respirations. Skin may be pale, may be diaphoretic. Our skin may be cool. We may have delayed capillary refill time. All that's because we're shunting blood flow. We've vasoconstricted, trying to get that blood to the vital organs, the brain, the lungs, the heart. You may have decreased urine output from the kidneys. One quick note, when you have a trauma patient, hypotension should be considered hypovolemic shock until proven otherwise. Have a high suspicion for bleeding in those trauma patients that are hypotensive. So in hypovolemic shock, we have inadequate circulating volume to deliver those nutrients to our tissues. The lack of oxygen delivery, it leads to anaerobic metabolism. If this type of shock is from bleeding, we term that hemorrhagic shock. And remember, it can also be from vomiting, diarrhea, or other causes. Um, One big thing to note is you may have insensible losses. Every time we breathe, remember one byproduct, we breathe out CO2 and water, right? So if we're very sick or we're breathing fast for a long period of time or even multiple days, we may have fluid loss that um, has added up. This is very common in sick pediatrics. So kids been sick, like with an upper respiratory infection for 2 or 3 days, they're breathing fast for multiple days. They may be losing a lot of fluid from that. We call that insensible losses. They may be dehydrated from that. Treatment of hypovolemic shock generally involves preventing further fluid loss. So this may be controlling bleeding, controlling nausea, and then providing fluid administration to try to correct that hypovolemia. In hemorrhagic shock, blood products are preferred to crystalloids to prevent, hemodilution and to replace the actual substance that you lost. Now remember that distributive shock is caused by systemic vasodilation. The container has essentially become too large relative to the volume inside it. There are three subtypes. There's anaphylactic shock, septic shock, and neurogenic shock. In anaphylactic shock, the body experiences an exaggerated immune response. This is from some type of exposure, like a bee sting, eating a peanut, something like that. This leads to the release of inflammatory mediators. You'll see this term a lot when reading about shock. This is just kind of different chemical substances that cause things to happen in our body related to inflammation. It may be cytokines, bradykinin, different kinds of histamines. So inflammatory mediators, just all those chemicals that cause the inflammation stuff to happen. So inflammatory mediators, they lead to vasodilation and increased capillary permeability, which just means your capillaries kind of get leaky, okay? And when those capillaries get leaky, you remember that the capillaries where gas exchange occurs. So when they're all leaky, we don't have effective gas exchange anymore. So this disrupts cellular respiration. The treatment of anaphylactic shock, it prioritizes the use of epinephrine for its alpha and its beta effects. Remember the alpha effects, we want that vasoconstriction, and then we also get the inotropy and chronotropy as the beta effects. Secondary treatments are going to be just fluid replacement, antihistamines like Benadryl, corticosteroids like Solumedrol, and bronchodilators is needed. But remember, the primary treatment for anaphylactic shock is epinephrine, not let's give Benadryl and wait to see what happens. Septic shock is very similar to anaphylactic in some ways. Systemic infection has led to release of those inflammatory mediators, and remember that causes widespread vasodilation and capillary leak. Treatment of septic shock generally involves, antibiotics or antimicrobial therapy. Fluid administration. The big common calculation you'll see for fluids in sepsis is going to be 30 mLs per kilo. And then you're going to use vasopressors as needed if their hypotension persists despite the fluid, or if they're severely hypotensive. Neurogenic shock is the last kind of distributive shock. It happens due to a spinal injury, okay? Um, the spinal cord has been injured and there is a loss of sympathetic tone. This leads to relaxation of that vascular smooth muscle. So we lose all tone in those blood vessels and we get widespread vasodilation. Neurogenic shock may also present with bradycardia. Um, the capillaries are often well perfused, so the skin may actually be warm. Remember, in some of the other shocks, we get that vasoconstriction, and that kind of clamps down our capillaries and it makes our skin pale because we're shunting. Well, we don't have that increased tone in neurogenic shock, so we may still kind of be pink and warm. Um, Treatment is going to involve good SMR, good spinal motion restriction, making sure we don't make that injury worse. Follow your guidelines. We're going to provide fluid resuscitation because remember that container is too big relative to the fluid within it, so we try to add a little bit more fluid. Additionally, we can consider vasopressors if the patient's hypotension is refractory to fluids. Be cautious in neurogenic shock patients because they may have other trauma as well. So remember that we prefer blood products in traumatic patients if there's possible internal bleeding. Just keep that into consideration. Now on to cardiogenic shock. So remember the heart has become an inefficient pump. The most common causes are like heart attacks, myocardial infarctions, as well as acute heart failure. This decrease in cardiac output, it leads to the inadequate delivery of nutrients to the tissues. Treatment in the pre-hospital setting is generally going to involve making sure you're transporting to an appropriate facility. If it's an MI, then they're going to need PCI or a cath lab, and these people need to be managed by a cardiologist. So they need to be taken to a place that can manage what's going on. You want to be real cautious with fluids and cardiogenic shock because remember, you have a bad pump. So if you put more fluid in a bad pump, it's just going to back up. And remember, when the heart can't pump forward, that fluid backs up either into the lungs or into the extremities. If the left ventricle is failing, that blood backs up into the lungs. If the right ventricle is failing, that blood backs up into the body. We do not want to overwhelm the heart. So a lot of times in cardiogenic shock, some guidelines may recommend doing 1 250 bolus to see if you get a positive response. And some guidelines don't recommend fluids at all in the setting of cardiogenic shock. Aside from fluids, early vasopressor and inotropes are used to improve that cardiac output. So medications that can vasoconstrict, and additionally medications that increase inotropy or that force of contraction of the heart. So we try to make that heart squeeze more powerful to increase our stroke volume and increase that cardiac output. The goal with cardiogenic shock is really you're trying to prevent death long enough that you can get them to preventative care or definitive care. Lastly, we've got obstructive shock. So obstructive shock is due to some extrinsic factor that leads to decreased tissue perfusion. The most common causes you're going to see within class and out in the field is going to be tension pneumothorax, cardiac tamponade, and pulmonary embolism. So treatment of these things is going to involve correcting the primary cause. So if a patient has a tension pneumothorax, we're going to do a needle chest decompression to try to relieve that tension. If we're unable to correct the cause, for example, if a patient has a cardiac tamponade, well, we can't do a pericardiocentesis in the field. So the only thing we really have to work with is a small fluid bolus. Um, so for a patient with cardiac tamponade, we might try a 250 bolus to try to increase that pressure just enough that we can get them perfused long enough we can get them to the hospital. Vasopressors may be beneficial. So for example, in a massive pulmonary embolism, if there's hypotension before they can evacuate the emboli, then they may administer vasopressors to try to keep an adequate map. So there are times in obstructive shock where vasopressors may be used, fluids may be used, but the primary goal is to correct the cause. whether that's decompressing attention pneumo, doing a pericardiocentesis for a cardiac tamponade. Treating obstructive shock involves trying to correct that original cause. All right, key points I want you to know, and you're going to see this slide again before it's over. So, in compensated shock, we still have an adequate blood pressure. The body's able to compensate, and we will probably slash possibly have an elevated shock index. So, our heart rate may be higher than our systolic blood pressure. Decompensated shock is when we have that hypotension. Okay, irreversible shock is when all compensatory mechanisms fail and essentially death is imminent. Hypovolemic shock is a fluid problem from inadequate volume. Distributive shock, it's a pipe problem. We've got massive vasodilation. The three subtypes of distributive shock are anaphylactic, septic, and neurogenic shock. Cardiogenic shock is a pump problem. And in obstructive shock, something is obstructing either the pipes, the pump, or the fluid. All right, now we are going to get into our scenarios. We have three of them, so bear with me. So we are dispatched to a 60-year-old female with altered mental status and weakness. Her family reports that she's been weak for the last 2 or 3 days and is acting confused starting this morning. They're also concerned about an ulcer on her foot that seems to be infected. So we find them. They're alert but confused. GCS of 14. Airways patent. Breathing is rapid at 28 per minute. Skin is pale and cool, and there's a weak radial pulse. Now, we note the ulcer on her foot. It seems red and swollen. Then we've got our baseline vitals. So we've got a heart rate of 122, a blood pressure of 70/40, respiratory rate of 28, satting 95%. End tidal is covered up on my camera, but I believe it is 25. Our temperature is 101, so we are febrile, and blood glucose is 120. Now that you've seen the call, I got some questions I want you to think about. Now, I'm going to read these off, let you pause, and then I'm going to go through them, okay? So is this patient in compensated or decompensated shock? What type of shock do you suspect? Should they get fluids? Should they get vasopressors? Is there anything we should consider telling the hospital? And why could this patient's respirations be elevated? So feel free to pause the video here, go through those questions, get what you think, and I'm going to go ahead and start knocking these out. So the patient was hypotensive, so we automatically know that that's decompensated shock. She's not able to effectively compensate anymore. We've also got elevated shock index. Her heart rate was much higher than her systolic blood pressure, so that should definitely be making us pucker, know that this is a serious patient. What type of shock? So we had a possible infection, right? That foot may be infected. So anytime we have that possible source of infection plus those shock signs, we should suspect septic shock, okay? So I really think that's what's going on in this patient. Should this patient get fluids? Absolutely. Remember, we have our 30 mLs per kilo that we try to get in them. Should they get vasopressors? Possibly. Say we get 500 mLs to a liter of isotonic crystalloids in this patient, and her blood pressure is still low or her MAP is still low. Absolutely, I'm thinking maybe some norepinephrine or a levofed drip to try to get their systolic up to if your protocol says a systolic of 90 or a MAP of 65 or greater. But definitely a candidate for vasopressors if their hypotension doesn't improve with fluids. And then lastly, why would their elevations be respirated? So remember, this patient is compensating for something, okay? So they had a low end tidal, and I believe it was 25. So they're in a state of respiratory alkalosis, okay? And they are compensating for a metabolic acidosis from the septic shock. So those respirations are elevated because they're compensating. And a lot of screening criteria for septic shock, like HAT criteria or SIRS, you may see elevated respiratory rate as one of the criteria, and that is because they are using respiratory alkalosis to compensate for their metabolic acidosis. All right, scenario 2. We are dispatched to a 52-year-old male complaining of chest pain and shortness of breath. They have a history of heart failure and reduced ejection fraction. So that heart, the amount of fluid that it ejects each beat is less than normal. Okay. They state that they forgot to refill their medication and they hadn't been able to take it. Ooh, that's not good. They state their symptoms started this morning and have gotten steadily worse, and now they feel like they're going to die. This is always a bad sign. Um, there are two things you always believe your patient. They tell you that they're going to vomit, and they tell you they think they're going to die. Always believe those two things. Um, Back to the scenario. The patient's airway is patent. Their breathing is labored with bilateral rails. They're absent radial pulses, and they are pale, cool, and diaphoretic. So a lot of bad signs, a lot of bad signs of shock. Heart rate, our baseline vitals, our heart rate is 104. Blood pressure is 66 over 48. Respirations are 30 per minute. They are satting 89%. Don't have an end tidal. I imagine it is low, or the end tidal's covered up for me. I imagine it's low. Temp is 97 degrees, and their blood glucose level is 110. All right, here we have similar questions to scenario one. Feel free to pause the video, go through these, find your answers, and I'm going to go through them. So again, this patient, are they in decompensated or compensated shock? So their blood pressure was low. They are decompensated. What type of shock do I suspect? This was a very black and white scenario. I think this sounds like a pump failure, right? This sounds like cardiogenic shock. The guy has a history of heart failure. He didn't take his medications that he needs to make sure his heart can pump effectively. We also had some rails or crackles in his lungs. So to me, that tells me his heart is not pumping forward and blood is flowing backwards into his lungs. Should this patient receive fluids, definitely be cautious. This isn't the patient you should put a liter bag in and then check their blood pressure again. This patient may benefit from a small fluid bolus, maybe like a 250 ml bolus, see how he does. If he gets worse, obviously don't give any more fluids. Um, but this is probably going to be a candidate for early vasopressors. Remember, in cardiogenic shock, we can use vasopressors as well as inotropes, or medications that increase contractility, to try to improve cardiac output to buy us time. Is there any additional diagnostics we should do? We need to make sure we do a 12 lead, because remember, an MI can be a cause of um, cardiogenic shock, so we want to make sure that we do a 12 lead on this guy. And then, are there any considerations we should report to the hospital? Obviously, if we have an MI, we should report that as a STEMI alert, or an OMI alert, whatever your service is using. And we should probably take this patient to. We should definitely take this patient somewhere with a cardiologist. Okay. All right. Last scenario. So we're dispatched to a college dorm for a 21-year-old male. Their friends called because of altered mental status. They report the patient was at a party last night and was extremely intoxicated. The patient is responsive to verbal stimuli, but very lethargic. They're also confused when you question them. GCS of about 13. Airways patent. Breathing is non-labored, a rate of about 22, so just slightly rapid. Patient's skin is pale and dry. They have a weak radial pulse, and the friends report that he's been throwing up a lot. For our baseline vitals, we've got a heart rate of 118, BP is 108 over 60, respiration is 22, sat 99%. End tidal is normal, I believe it's 36. Temp is 98.1 degrees, and blood glucose level is 88. Again, I'll give you a minute to look over these questions, pause the video, go through them, see what you would do, and I'm going to run through them. Is the patient in compensated or decompensated shock? So this patient had an adequate blood pressure. They had radials. Um, they are in a compensated shock. Now remember, our heart rate was higher than our systolic blood pressure, so this patient had an elevated shock index. So this is a good sign, or this is a assessment sign that the patient is in a state of compensated shock. Now, what type do we suspect? He's been vomiting, losing fluid volume. So I think that hypovolemic shock is the most likely explanation for this. Should the patient receive fluids? Absolutely, this is a good candidate for a good large fluid bolus. Probably not going to need vasopressors unless they decompensate later and the fluids don't fix anything. But I would expect this patient to respond very well to fluids. Should there be any conditions for other medications? If the patient's still actively vomiting, some type of antiemetic, Zofran or Phenergan, may be very useful to kind of stop that vomiting or minimize that vomiting or discomfort, and kind of help improve their hydration. So remember, with hypovolemic shock, if we can, we want to stop any further fluid loss This is easier in trauma, kind of, because you can stop bleeding as best as possible. But in a medical hypovolemic shock, say from vomiting, if we can keep them from vomiting more by administering an antiemetic, this can kind of help us stop that fluid loss, and then we can focus on getting fluids on board to try to replace that. Now, I told you you'd see this slide again. We're going to recap this again. So compensated shock, we have an adequate blood pressure, and we possibly slash probably will have an elevated shock index. Decompensated shock occurs when that hypotension occurs, that blood pressure finally drops and we can't compensate anymore. Irreversible shock is when nothing we can do can correct it, nothing the body can do can correct it, and death is essentially imminent. Hypovolemic shock is a fluid problem. There's inadequate volume, either from bleeding or some other type of fluid loss. Distributive shock is a pipe problem. You've got widespread vasodilation. Three subtypes are anaphylactic, septic, and neurogenic shock. Cardiogenic shock is a pump problem. The heart can't beat strong enough, fast enough to get the fluid where it needs to go. And then lastly, obstructive shock is from some other cause that obstructs the pumps, the pipes, of the fluids. Things like tension pneumo, cardiac tamponade, pulmonary embolism, anything that obstructs one of those functions. So I hope that helped you get a little bit better understanding of the pathophysiology of shock. Continue to study. These are the two references that I use, the PHTLS book and as well as the AMLS book. They're great resources. Continue reading, continue studying, use the last little bit of the spring break as an advantage. I hope you enjoyed the video. Please let me know any questions you may have. Everybody have a good spring break. We'll see you in about a week or so. Thank you.